Welcome to another episode of our still unnamed podcast, which we still need a name, guys. You guys do realize we can't just have an unnamed podcast, unless you guys want to call it the unnamed podcast, which is
I
cool
think that's
too.
what I was actually going to suggest. Unnamed would be.
I like the unnamed podcast.
Yeah. All right, we
Sticks
can
to
do
the
that.
theme of not participating and all that other stuff.
All right, we got a very packed episode for all of you guys today. We got some hot topics that we're going to be covering, and then we have a deep dive into a big change that's coming in the drug pricing industry with a lot of Medicare patients and our elderly patients. So we're going to jump straight into it. First topic we wanted to just cover, it's a hot topic. It's the walkouts that have been happening across CVS's and Walgreens across the nation. So if you guys remember last week, I think it was in Kansas City, CVS had about 65 stores that all had pharmacists and pharmacy staff walking out because of, just unsafe working conditions and overworked and understaffed. So that happened with CVS. This past week, the same thing happened with Walgreens across what was estimated to be about, I think, 500 interested locations out of 9,000, but there's no actual number of how many Walgreens stores actually had staff walk out. But the general gist of kind of what's going on, bottom line is the staff at the pharmacy burnt out at all, whether it's chain pharmacy, I can speak from personal experience, and independent pharmacy. Overall, staff at pharmacies, whether it's pharmacists, technicians, everybody is just simply burnt out. There's more demand than there is supply of staff to be able to take care of it. And this trickles down into a potential problem of, patient safety, medication errors, dispensing errors, lack of consultation. I mean, the list goes on of everything that could go wrong when there isn't adequate staff and adequate help to make sure that every patient's taken care of at the highest level. What I guess both of these companies are trying to do after the walkouts, they're trying to insert more staff into areas that need that additional staff. They're also trying to mitigate hours and increase pay. It's all things that have been promised, as far as I've heard in the past, but hasn't really come to fruition. But I think these walkouts are kind of creating more awareness of the actual issues that are going on day to day at these pharmacies. And so it's bringing it more to light again, with all the news coverage and with social media. It's definitely being amplified more than it used to be in the past. I don't know if you guys remember, there was always strikes and things happening at healthcare industries. And Kaiser had their strike, and all these companies used to have strikes, but it wasn't very known. But now I think it's becoming more of a prevalent issue, and more people are becoming aware of it. So I just wanted to get your guys' take of what you think is actually going to come out of all this, like what the results are going to be, if there's going to be any results, or if there's not going to be any changes at all. What do you guys think?
You can take a stab at it. I mean, obviously, there's a lot of labor movements going on across the country. We've seen a lot of workers strike. There's a lot of strikes out here in Hollywood. I know earlier this year we had a few other industries, folks going on striking, and obviously it resulted in significant improvements in their benefits and wages.
Mm-hmm.
I know Kaiser just had a strike about 75,000 healthcare workers, I think mostly nurses, pharmacists, and other staff. That was resolved this morning. I think they came to an agreement earlier today. We're recording on Freaky Friday the 13th. So it was resolved earlier today. But this is obviously a sign that pharmacists, if they're going to be serious about this, if you're in the retail setting and you're dissatisfied with the quality of life, you're dissatisfied with the working conditions you have, the inability to provide good patient care, this is probably the best opportunity to band together and takes these types of steps to maybe unionize, to strike, to demand better working conditions, higher wages, and the more better work-life balance. Obviously, you mentioned it, hit on the dot. Pharmacies are the highest stress environment. I mean, pharmacists are literally the backbone of like COVID immunizations, and right now, boosters, flu shots, RSV vaccines on top of your regular workload, and on top of reduced reimbursements, on top of losing staff or being understaffed. So it's a lot of stress for pharmacists and pharmacy technicians and the entire staff. So I think this is a good opportunity for them to do what they're doing. I really hope that they can band together and do these types of things more frequently, and there'll be a positive outcome. However, I am pretty pessimistic on anything actually happening, I guess is the best way to put it. I don't think this is going to go beyond a couple of stores in a couple of select markets. And ultimately, I don't think it's going to result in any meaningful change within CVS or Walgreens. This news will just blow over and kind of go away. But I hope I'm wrong. I just don't really see anything changing anytime soon, unless there's big collective effort by everyone across the country, which doesn't seem to be happening. It just seems to be more scattered.
Yeah, the insight I can give you, I don't think pharmacists are unionized. So it's kind of difficult for a lot of them to sort of band together and say, hey, look, we're striking because we have really poor working conditions. And I think, for our listeners who are, kind of hearing this for the first time, you're probably skeptical. Like, what do you mean by, really terrible working conditions? What do you mean by they're burnt out? To sort of give you some sort of understanding here, out of like 1,000 pharmacists that were surveyed, I believe the number they said that pharmacists can safely verify roughly up to 150 prescriptions in a day in an 8-hour shift. From a lot of pharmacists who work over at Walgreens, Rite Aid, CVS, so on and so forth, they are exceeding that number by a lot. I mean, I know some pharmacists that verify 300 to 400 per day. On top of that, they're required to do their clinical consults, having face-to-face interactions with their own patients. They have to talk to the doctor. There's things called prior authorizations where you have to communicate and work with the insurance to get medications approved and paid for. On top of that, we're required to go beyond the prescription dispensing role where we have to give a professional service of administering vaccinations. On top of that, there's also professional services of medication management therapy, which requires a lot of face time with customers and patients. I've seen some reductions that happen where some stores have less clerical roles, so the pharmacist has to end up taking on the role of the point of sale register. So a lot of these things, when you have a pharmacist who's, a trained doctor handling a lot of these different tasks and not getting the support that they really deserve in some of these stores, it becomes a zoo. And this is kind of why a lot of pharmacists are striking, saying, look, I can't work in this sort of condition. I'm doing everything here, but my primary role and focus is take care of my patients. I can't do that if I'm having to give someone change at the register and having to pick up a phone call regarding, how much is pricing on a drug. And then I have to deal with, my own patients getting their medications out and dispensing it. It's a lot for one pharmacist to take on. And sometimes one pharmacist has to do 300, 400, 500 scripts in a day. It's just not feasible.
Yeah.
I hope something does change. I mean, this walkout is definitely needed. And, I'm more optimistic in the sense that a lot of pharmacists who are interested in going into retail are, thinking about this twice and saying, look, I'm not going to take this. I don't want this sort of, working environment to be in.
I think there's just so pharmacists are compensated just on their role in the pharmacy, but pharmacists, we mentioned this before, don't get compensated for the professional services that they offer. And you mentioned earlier, there's other things besides just dispensing medications that pharmacists do, like prior authorizations, like medication consults, medication therapy management. We don't get paid for any of that stuff. That's just, it's expected, which is insane because you've done prior auths. They take back and forth communication with doctors' offices over and over to get notes, to get info. It's hours and hours of work for us to then just be able to fill the prescription at the end of the day. And this is, the prior authorization role is supposed to be done by the provider's office, but they don't have time. So they put that burden onto the pharmacy. And if one of the two parties doesn't do it, patient doesn't get their medication. So it's just, there's a lot of ancillary tasks that pharmacists have to do that there isn't enough compensation for. Balancing between that optimism and pessimism. So Walgreens has a new incoming CEO, and when they interviewed him, he didn't mention the walkouts once, which I thought was pretty alarming, considering that you're taking the role of CEO for a large company that just had a nationwide walkout that week, and to not even address the topic. I think that was I don't think that was right. I think they just brushed it under the rug. So I'm just hoping that a similar situation doesn't just keep popping up where they just brush it under the rug whenever they can. But we'll see. I am too optimistic because there's a lot more coverage about this. There's a lot more voices being heard. I just don't know if it's going to be something that actually pans out into help for all these pharmacies. But anything else on this before we move on?
Yeah, I mean, if you have a story, you're a pharmacist and you're working, at one of these retail stores, we'd love to hear your experience. So feel free to reach out to one of us and tell us more, and we'll definitely mention this on the next podcast.
Definitely.
All right, let's segue into our main topic for the day. So there has been negotiations between CMS, which is what's CMS? Centers for Medicaid
Centers of Medicaid and Medicaid Services.
Services, yeah. With the Inflation Reduction Act that was passed, the overview of this, there's about 10 medications that have gone through kind of the first round of negotiations, 10 different companies with one individual product per company. They're trying to essentially negotiate the prices down both for out-of-pocket costs and for the cost of the medications overall for Medicare patients. There's a couple things to highlight in terms of what this bill entails. The first biggest thing is the changes for any patients that have a Part D plan. So just to give you an overview of the Medicare system, there's Part A, Part B, there's a Part C, and then there's Part D. So we're going to be focusing on the Part D today, which is for the prescription drug costs. Within the Part D coverage, they are renegotiating so that in any year, a Medicare beneficiary should not have to pay more than $2,000 out of pocket in a calendar year, which is very substantial. It's very impactful as well, because I've seen prescriptions come through where one single fill for one single medication for one patient is an out-of-pocket cost of $2,000 every month. So if they're going to be capping that of $2,000 a year, it's going to have a trickle-down effect on a lot of things, which we're going to be talking about today. The other big thing that was brought up was the inflation prices of drugs versus the general inflation rate year over year. So they did a study, or just an overview of last year's increase in the inflation rate versus the drug cost inflation, and the drug cost inflation exceeded the yearly inflation rate. So just keep that in mind when we're having this topic of conversation either as well. And then the last thing was the healthcare subsidies. So there's certain patients and members that buy their insurance through like marketplaces, and within these marketplaces, they have, I don't really know how this works. Like it's like an insurance marketplace that you go, and then based on the medication that you're taking, they kind of match you up with a plan that's going to fit you best to lower your drug costs for the entire year. They're redoing or renegotiating that. So there's an average annual savings, I think, of around $1,000 for some Medicare patients. And they shouldn't ultimately be paying any more than about I think it was 8.5% of their annual income towards this healthcare insurance premiums. So essentially, you shouldn't be paying any more than 8.5% for your insurance. So those are the three big things that are kind of being negotiated with this Inflation Reduction Act plan. But Pogos, I'm going to let you take over because this is your topic of expertise. Subject level matter expert here.
So yeah, I think Amri did a great introduction. I think I just wanted to start off with the first thing was that last point you made about the subsidies.
Mm-hmm.
So that was an extension, I think, until 2025 of subsidies for the marketplace. Basically, the Affordable Care Act established a marketplace where insurance companies can offer people who are, let's say, an independent contractor who are not provided health insurance benefits through their employer, a place where they can purchase commercial insurance coverage through that marketplace. So in California, we have Covered California. I think there's like healthcare.gov, and each state operates their own like marketplace. So those subsidies are for people who are a certain percentage of the federal poverty level. I think if you're going anywhere from 400% down to like 150%, you get a monthly subsidy payment on your premium. So that portion of the IRA is applicable to those individuals, and just extended the subsidy payments to help basically bring down the cost of their monthly premium payment for the purchased insurance. But this is like commercial coverage, not necessarily tied to Medicare.
Mm-hmm.
So
So
I just want to.
so is it for Medicare patients specifically, or it's for
No,
everybody, right? Because Covered
no,
California is for everybody.
that's yeah, covered California non-Medicare. So commercial, like if you were to purchase a PPO or HMO plan off the exchange, like the covered California marketplace,
Right.
that's a subsidy based on your income. So if you're earning 200% of over the federal poverty limit, you'll receive more of a subsidy, whereas somebody that's a higher earner won't receive any subsidies towards their premium payments. It
And
has
so that's
nothing to
just a
do. It's not.
reduction, right? And just like their monthly premium.
Yeah, this is just
Yeah.
extending those subsidies until
Okay.
2025. Or that's that one component of the IRA. But obviously, this is a large bill that was passed last year by the Biden administration. And I wanted to give the audience, like you did a great job of kind of priming them on Medicare, but I want to take a step back and really explain what this is. And
Yeah.
Medicare, federal insurance that was formed back in 1965, signed into law by LBJ. And what it was designed to initially do was provide healthcare benefits and coverage for those over the age of 65, those who are on disability, permanent disability, or those who have end-stage renal disease. Initially, Medicare had that Part A that you mentioned, covered
Mhm.
hospitalizations, and Medicare Part B covered outpatient services. So this is like doctor's office visits and certain medical equipment and preventative services that were done outside of the hospital, and other things fall into these categories as well. And when you mentioned Part C, that is what's now come to be known as Medicare Advantage. That is a combination of Medicare Part A and Part B. That is not governed through or administered through CMS, the Centers of Medicare and
Okay.
Medicaid Services, but it's done through private or for nonprofit organizations, basically plan sponsors. These could be your Humanas, your Aetnas, your what's it called, United Healthcare. These big organizations that will manage Medicare Advantage plans. And then the last component was Medicare Part D. This is the most recent component. It was formed in, I think, 2006, signed into law by President Bush. And this is the first time that Medicare beneficiaries had prescription drug benefits covered. So a lot has come since 2006 with Medicare Part D. I think you mentioned one of the things that, patients had huge out-of-pocket costs, $2,000 per month on medications. And the ACA addressed a lot of these loopholes back in 2012, where they, kind of closed the donut hole, if you remember that. And there hasn't been really a lot of changes since the ACA kind of did a few little things for Medicare Part D, but the IRA, which we'll get into, has a lot of changes that have transpired over the past year, and I'm going to dive into them. But before I do, I want to kind of take a pause and see if you guys had any questions or anything you wanted me to clarify sort of on the history of Medicare and how we got to where we are today.
Oh, I just have a quick. So you said, I mentioned the $2,000 out of pocket.
Mm-hmm.
Is that calculated just by, the insurance covers a certain portion and then the rest is just the patient's responsibility?
It's a good
And
question. So
there's no assistance with that, or?
but currently, the way Medicare is set up, it has 4 different coverage stages. There's a
Mhm.
deductible phase for a couple $100s. Then there's this thing called the initial coverage phase. In this phase, there's a shared responsibility between the patient and the
Mhm.
plan sponsor. So they're, whoever's providing their Medicare Part D services. This could be like SilverScript or Express Scripts or Humana, or these could be more of a smaller regional plan. Just depends what the patient is enrolled in or the beneficiary is enrolled in. So there's a shared responsibility there. And then once they reach a certain dollar amount in drug spend, they'll move into what's called the donut hole. And the
Mhm.
donut hole, the coverage gap, which is what I kind of mentioned, the ACA did a good job of closing. There's a shared responsibility between the patient, the plan sponsor, and the pharmaceutical manufacturer in that space. And then after another threshold is hit, then they enter this stage called the catastrophic coverage phase, where the risk is now shared, or the cost is now shared between the patient, but it's capped at 5%,
Okay.
the plan sponsor, and Medicare picks up the rest. About 80% of that is where Medicare is picking up the costs in that catastrophic phase. But very few patients enter that phase. It's basically your patients who are on chronic medications, brand medications, or specialty medications are the ones that will generally trickle into that space. And to answer your question, Arma, that $2,000, it's going to really depend on the patient,
Mhm.
their income level. If they're dual Medicaid and Medicare recipients, their cost structure and cost share is going to be totally different than someone that's a retiree that has a a high social security payment. They have, they're more well off. It'll vary really for them versus somebody else and what kind of plan they're enrolling, because the general structure of how things are set up is really going to be different from one person to the other. So it's kind of hard to say. Someone may have a flat copay or somebody may have a 20% coinsurance. So it's really going to depend patient to patient and what plan sponsor, what Part D plan they're enrolled into.
So if I understand correctly, you said there's 4 tiers or 4 stages. So at the very top stage in the beginning, the
Mm-hmm.
patient's responsible for more of the cost. Is that correct? And then as it goes down, the patient's share of cost or responsibility trickles down between each tier, correct?
Correct.
Okay.
Yeah, the
And then
deductible.
catastrophic being like the highest means that with Medicare plus the plan will cover most of it, and the patient just has a small portion to cover.
Correct.
Okay.
It's once the patient hits catastrophic. So as you hit it around the dot, basically deductible. Most plans generally waive this period. So patients generally start at the initial coverage phase, and then they'll go into the coverage gap. And this is again, very few patients hit catastrophic, then their cost share goes down and is capped at a 5% or a certain dollar amount, again, depending on kind of like what plan they're in, their financial status, and so on.
Okay.
Yeah.
I had a general question here, but how many people are on Medicare? And if someone were to go on Medicare, how would they have to be eligible for it?
Yeah, great question, James. I believe last I checked, the numbers were somewhere north of 65 to 70 million Americans are on Medicare. So by far the largest payer in the country as a single entity, right? Medicare is federally administered, unlike Medicaid, which is a kind of a shared responsibility between the federal government and the state government. So eligibility is going to differ state to state, California to Nevada to Utah to Colorado, for example. But Medicare eligibility, age 65 and older is one. 2, you have a permanent disability award from Social Security. And 3 is you have end-stage renal disease, which is when your kidneys are no longer functioning and you would need to be on dialysis. So those are the 3 main categories of being eligible for Medicare.
And then you said there's Medicare and then Medicaid, so patients can't have both?
Correct.
Right?
Yeah, you can definitely be in both. Again, Medicare those are the 3 eligibility criteria to meet the requirements to be in a Medicare plan.
Okay.
But Medicaid obviously is going to differ state by state. So I can only speak to, let's say we live in California. If you're at a certain income level, you qualify for Medicaid. So Medicaid and Medicare would then both be providing you with benefits. Medicare would take primary, meaning that they're the first payer, and then Medicaid is the payer of last resort and will be secondary. But there's obviously a lot of benefits to lower income seniors who are on a fixed income. If they have Medicaid, it will offset certain premiums. Like for Medicare Part B, there's a premium about $150 plus a month, and Medicaid will cover that. It will also offset your Medicare Part D premiums and also offset some of your co-payments. So that's why I was saying it kind of differs from person to person. And also you'll certain drugs that are not covered by Medicare, because Medicare doesn't cover certain medications like things for weight loss. It doesn't cover certain medications. Medicaid may pick those up and cover those. So that's obviously an added benefit for lower income individuals and seniors who are on a fixed income.
Okay.
Some good questions. So if there's nothing else.
A lot of complication before even
it's a lot.
Getting the medication.
It's obviously, it's a lot of, Medicare is not easy. I mean, there's, armies of, I shouldn't say armies, of teams, massive teams of individuals that work just to basically understand the compliance and regulation behind being in a Medicare plan and being a plan sponsor. And there's, CMS does a great job of really enforcing the rules and really being on top of it just to ensure that their beneficiaries are getting the best possible care available to them. Mm-hmm. And I think just kind of to focus on the impact of the IRA for the remaining of the time, this is honestly a big change. There's a lot of unknown. There's, what we're talking about today will be maybe different if we were to have this conversation in a week or a month, and definitely in 1 year, because I talked to colleagues and most of them say we really don't know what's going to happen until probably sometime like next spring or even next summer, with what's actually going to be the results of like the impact of the IRA. So I kind of wanted to kind of jump into what happened with that. So there's a few things, and Alma, you hit a couple of them during the conversation, but I wanted to kind of start off by introducing a few topics, and this is all kind of beneficial. Everything that really happened with the IRA had a lot of positive outcomes for the beneficiary, the patient. Obviously, the federal government's benefiting in this in terms of the money that they're going to save, and it's not just only tied to like the drug negotiations. There's other factors in this too. But we'll kind of discuss like how it benefits patients, how this drug negotiation process is going to go down, and I also really want to talk about some of the downstream consequences that are not really being brought up in the media that may have some impact to other individuals that are using medications. So as you had mentioned, IRA passed last year, and some of the things that it introduced for Medicare. One was it set a $35 cap on insulins. So this is huge.
Yeah.
This is like totally flies under the radar. No one talks about how big this was, but one of the things that people were paying hundreds of dollars a month for was their insulin. And this is like a life-saving medication. People need to take this every day. Without this, it's, you've heard many stories of people dying by rationing their insulin. So this is phenomenal. This is probably my favorite thing that came out of it, was this and the $0 copay on vaccines, which I'll get to next. But capping insulins at $35 a month, this is the biggest news to me. After this was announced, all the big pharma manufacturers, Eli and Lilly, Novo, Sanofi, all came out and said they're reducing the prices of their insulin. So it's been like great news across the entire industry, I think, for patients who are diabetic. And I think this is probably my biggest takeaway. Another thing, the IRA is $0 payments on vaccines. I'm huge on preventative care. And prior to this, patients may have co-payment on a flu shot or shingles vaccine, a vaccine for hepatitis. Now it's eliminated. It's $0, which just removes a barrier for a patient to get a vaccine that they otherwise would have said, hey, you know what? I'll spend that $5 or $20 on a bus pass or meals for a couple of days. So I think those are two big takeaways. A couple of the things that are taking place was there's an extra help in Medicare. We mentioned people that have Medicaid may also get lower monthly co-payments. They expanded that to include a larger subset of the population, or out-of-pocket maximum, which did not exist and now is in place, which is going to be greatly beneficial to a lot of people, knowing that, hey, I'll never spend more than $2,000 a year on my prescription medications. And then another great benefit to patients was a cap on premiums at 6% from 2024 to 2029. So they're not going to expect a huge inflation in terms of their monthly premium payments they're making. So that was good.
Just a question. So it seems like this bill has a lot of reductions in favor of the patients that are ultimately getting the medications and the drug, but the cost and it's still a matter of money. So is it just that the federal government's picking up more of the slack, or is it more that are these negotiations where ultimately they want the drug manufacturers to lower their prices? Is it kind of a blend of both? Is that what the ultimate goal is?
So that's a good question. I was actually just going to get into that towards the end of the conversation, but I'll basically hit my next
just
point.
Give me an overview.
Sure. Yeah. So just as an overview. So my next point that I was going to bring up is, remember we talked about those 4 coverage stages with Medicare, that deductible, initial coverage, the coverage gap, and the catastrophic phase. Well, that's going away. That entire thing, CMS is getting rid of that entire system. And what's going to end up happening is the deductible will be there, deductible phase. There'll be kind of like a middle phase and a second phase. And right now, I kind of mentioned the risk is shared between the patient, the plan sponsor, pharma, and then at the very end, the government picks up about 80%, right? Yeah. Well, in this new layout, the risk that the government has significantly decreases. It goes from 80% to less than 20% at that catastrophic phase. So they're pushing a lot of the responsibility, the financial responsibility, onto the plan sponsor and to pharma. So that's what I was saying. There's going to be some downstream consequences, because if premiums are capped at 6%, meaning that the plan sponsor, the entity that's running the Medicare Part D plan, that's providing the services, cannot increase premiums. The member out-of-pocket costs are capped at $2,000, so they can't get more money from the beneficiaries. They're not going to be able to, through co-payments or co-insurance or through premiums. Government subsidies are decreasing because the government's no longer going to have that 80% catastrophic coverage insurance available to subsidize plan sponsors. It's falling mostly on them and pharma. So this is where a lot of the pushback is coming. You're hearing from the pharmaceutical manufacturers, but there's obviously a consequence to these plans that are going to be operating and providing these Part D services. That I was going to get to a little bit later on in the conversation, but you bring up a very good point that it is ultimately about dollars, and there's a lot going towards that's going in favor of the patient, which is always a good thing. The government's obviously reducing their costs, but someone has to pick up that spend. And I think this is where it's going to get very interesting in terms of what I've been hearing and what I've been seeing that could potentially happen.
Okay. Wow. So, I mean, to me, it sounds like one of the industries, either pharma or PBMs, one of them is going to get squeezed from the result of governments reducing their expenses, as well as their own beneficiaries, their own patients having to spend less. Is that kind of, a good way of looking at it?
That's definitely a good way of looking at it. And one thing I did want to share is just quickly was this chart that I have here. Let me know if you guys can see my screen that I have up. This actually is a good primer for the remainder of the conversation. But yeah, James, 100%, you're hitting it on the dot. There's basically the patients are obviously the most important. We know somebody that's on Medicare in our family, our friends, our patients that we work with in the pharmacy, and to see the benefits that they're going to get out of this, whether it's lower monthly copayments, lower access, easier access to vaccinations, lower premiums. It's all going to be a net benefit for the patient. The savings for the government, I believe the estimates were 90 billion, if I'm remembering correctly, over a course of 10 years is what was projected. And that obviously includes the next half of this conversation, which is the price, the negotiations with pharmaceutical manufacturers. But it's clear, it's yet unclear who's going to be the loser. Is it going to be the pharmaceutical manufacturers? Is it going to be sponsors like the PBM or the health plans? We don't know.
I would think that, the Inflation Reduction Act here would possibly lead to higher medication costs for new drugs that are entering onto the market. Because if I was, a pharmaceutical company and I'm told, hey, look, there's going to be less money flowing into this industry. Well, if I can't raise drug prices, my standard 3%, 5%, 10% to pay for overhead, then that just means the next drug that I'm going to release that, gets approved by the FDA, I'm going to just jack up the price. I mean, that's the way I'm looking at it if I, were to come up with a new drug on the market. But I mean, so, it's all game theory at that point, right?
I feel like you saw my notes because you just predicted exactly where I was going to go to as one of the consequences of this is potentially pharmaceutical manufacturers launching medications with higher list price. So if you're not able to increase the cost of a drug, there's a formula that Medicare is basically going to set for certain medications that are used under Medicare Part D. If it increases that higher than the rate of like the CPI, the Consumer Price Index, you have to pay an excise tax. So you might as well just set that high, knowing that you can't go more than CPI every year. So that's obviously something that pharma is very clear about. That a drug that they may have launched that would have cost $700 a month may now start at $1,700 or $2,700 a month. Who knows? Obviously, to be determined. But I just kind of want to briefly go over that next half of this. So I think if you just take a look at this timeline, and basically many of these things went into effect starting this year. The copay on insulins, the $0 vaccine coverage. Next year, we'll start to see a few more things expanded, including the extra help and elimination of that catastrophic coverage phase. And then the out-of-pocket cap goes into effect in 2025. But just on August 29th, I believe, and I'll pull up that article if you give me a quick second here. Medicare announced the top drugs that they're going to focus on. And let me know if you guys can see this here.
Yep.
Yes. Yep. All right. Perfect. So basically, Medicare announced on August 29th the top 10 drugs that they're focusing on for their price negotiations. So for the for plan year 2026, they're going to target 10 Part D medications. And then in 2027, they're going to target 15 Part B and Part D drugs. And then this will increase to 20 Part B and Part D drugs in 2029. And I think I may have misspoke. It's 15 more Part D drugs in 2027, 15 Part B and Part D in 28, and 20 Part B and Part D in 29. So this is the first 10, and I guarantee if you guys take a look at this list, you guys are very familiar with these medications. For the audience, these drugs, they're anywhere to treat blood clots, to treat diabetes, to treat heart failure, and some of them are specialty medications used for various inflammatory conditions like rheumatoid arthritis or psoriasis. So Medicare has been spending billions of dollars on these drugs. These are the most highly utilized, meaning the most patients taking them, and the drugs that have the most spend. So there was a lot of pushback from pharma. I believe a few of the manufacturers like Merck and BMS and a couple others filed lawsuits claiming that this is
eight
eight
total
manufacturers. There you go. Thank you. Claiming this is basically unconstitutional. I believe a judge struck that down, and they just agreed to enter this negotiation phase with CMS. I believe negotiations are currently under the way, and we won't really see anything listed or any of the results of the negotiations until spring to late summer of 2024 for these rebates or these negotiated prices to be in effect for plan year 2026. So obviously the current negotiation process is going to be entirely under the wraps, but these manufacturers are given three options: either opt into negotiating and take the price, don't negotiate and remain in Medicare but pay a tax, or three, if you don't want to do option A or B, then you're out of Medicare and Medicaid services, meaning the federal government essentially won't be paying for the medications for their beneficiaries. So they were kind of put into a situation where the backs are against the wall and they had to step in and start negotiating with the government. So I think in terms of where this will go, it'll be interesting to see the outcome of this. Many of these medications can go from anywhere from $1,000 a month up to $7,000, $8,000, $9,000 plus a month. So it's going to be very interesting to see how much the government's able to bring the cost of these medications down and what this entails going forward. I mean, this list is only going to grow from 10 this year to 15 next year, and it's going to keep adding up. So it's going to be interesting to see how this widens and what's going to take place after that. And then I just kind of want to just pause here before we kind of talk about the complications and additional considerations.
Yeah, I mean, the list of drugs here, you're talking about Eliquis, Jardiance, Xarelto, Januvia, Farxiga, and Entresto. These are really big medications. Like when I owned my own pharmacy, I was dispensing this left and right. So this does, impact a lot of different people.
I mean, they're life-saving medications. If a lot of these, you don't take them, it's hospitalization and then ultimately death.
Yeah.
If you're not compliant with these. So I get the whole cost thing of, if a patient can't spend $1,000 when they're only getting $1,500 a month for like their Eliquis prescription, and if they don't take it, well, they're just, a few months away from a hospital visit and potentially worse.
Yeah.
So that's insane.
Yeah.
Just $16 billion on one single medication for 1 year. That's a astounding number.
Yeah, it's a lot. Eliquis, Xarelto, Jardiance. I mean, these are like obviously the top five are, almost everyone is on one of these. Any senior, any elderly patient you encounter is taking one of these medications, and obviously positive incomes. I mean, you're talking about someone take a blood thinner and not have to deal with the tragic outcome of a stroke.
Right.
Then so it's obviously these things are life saving. They're preventing hospitalizations. They're increasing quality of life and obviously helping folks live longer and healthier. But Medicare really targeted these medications. These are the highest spend, highest utilized drugs. There were certain caveats and exclusions that they weren't focusing on, but I can only imagine the next subset of these medications is going to be interesting to take a look at and see what they are. But I don't know how the outcome of the negotiations will go, or what the pending litigation is going to result in. But I think it's a step in the the positive direction in terms of, again, putting the patient first and really focusing on helping lower costs for the patient. And also another thing too is basically making sure that Medicare is around for future generations. I mean, we take this thing for granted, but it's a large component of our GDP. It provides a great service, but we have to make sure that, as the younger generation ages too, that they have these same benefits and that safety net available to them as well.
I have a question. So,
Mhm.
like a lot of these medications, negotiations are starting now. We're not going to see any actual price changes till 2026.
Mhm.
Are any of these medications ready to go generic within the next 3 years, 3 to 4 years?
That's a good question. I know from this list, Stelara may have some biosimilar competition coming out, but that's really like, I'll take it out with a grain of salt. I think it was scheduled for next year, but those things always get litigation. If you look down there with Novolog, there's obviously they kind of basically self-imposed the cap on the price of insulin already from the manufacturer, so I think that will just drive spend down there. Same thing with Enbrel, another one of those that may have some biosimilar competition down the pipeline, but nothing. Most of these are relatively, I don't want to say new, but newer. I mean, the Farxiga, Jardiance, these came out. This whole class was introduced while we were in pharmacy school, so I think there's still some patent protection for a few years, but I wouldn't say anything within the next 5 years for these medications.
Isn't it usually seven? Is it 10 years or is it 7 years? I forgot.
20 years from the first time the chemical entity's been discovered. And then I think it's 20 years, but there's so many ways to keep
To lengthen that.
the lengthen your patent
Okay.
protection. I mean, yeah.
Yeah, I just looked up Eliquis right now. It says it's projected to go generic sometime between 2026 and 2031. But they entered into a generic agreement back in 2007. So just put that timeline into
Yeah,
that's
that's
what 20, 24 years potentially.
Yeah,
19 to 24 years. That's crazy.
Yeah, it's pretty hard to say. That's why I just kind of take it with a grain of salt. And it says generic competitions, unless we know for sure it's going off, which I can't say confidently for any of these. I would say nothing within the next 5 years. I hope I'm wrong.
I mean, my point was like, if they're going to negotiate for 3 or 4 years and then they end up going generic, it's like all that work is essentially for nothing. Like, what's stopping these pharma companies from just kicking the can down until it goes generic? And they're like, all right, well, now we have an Eliquis, a better version of Eliquis,
Yeah.
and that one's going to come out, but that one's going to cost $5,000 instead of $1,300.
Yeah,
because it's a better drug and it's better than everything. So
exactly.
But
Exactly.
all right.
Pogos, I got a question for you. I mean, the Inflation Reduction Act here, it seems like it's going to be, shaking a lot of different trees, especially for these drugs that are listed. But, some of our listeners here, they're probably not on Medicare. So how would this benefit, our non-Medicare beneficiaries or non-Medicare people? Say it's someone who gets insurance through their own employer, or perhaps they're, someone like, your age or my age, and, we're working for an employer or between jobs. How would it affect them? Do you anticipate there would be indirect costs associated with, raising prices or lowering prices? Will insulin still be $35 for everyone here, or is it just, again, for Medicare beneficiaries?
So that's a good question, James. This is only for Medicare beneficiaries. So Medicare is, as we mentioned, the largest payer in the country. They're using the collective power to drop down the prices of these medications. This, unfortunately, I don't see this trickling down to payers. So I don't think it's going to really, Medicaid is operated totally differently than Medicare. And then when it comes to individuals that are, working or paying for their own insurance or paying out of pocket for medications, I don't anticipate any changes there, except for the insulin. The insulin, I don't see the companies increasing the prices. I think when they dropped it down to $40, I anticipate it staying around 40, and maybe slightly increasing year over year. I hope that doesn't change. But in terms of the rebates that Medicare will negotiate, I don't see those prices being passed down to consumers outside of Medicare, unfortunately. And I think when we talked about potential complications, you guys hit it on the dot that one of the things that these manufacturers may do, knowing that they're limited in terms of how much they can increase the price of a drug year over year, I think we are going to see higher list prices, which will have downstream consequences to individuals not in Medicare. So if you have a high deductible health plan and you're paying $500 a month for a product, if you switch over to the new drug and now it's, it costs $5,000, well, you're going to have to pay, that huge deductible or that huge co-insurance on a much more expensive drug. So I think it may have some negative consequences to individuals and on private insurance or who are paying cash for medications because of the potential increase in list prices on new medications. I also think there's another issue where pharma may offset paying these subsidies. Basically, if they're going to be subsidizing Medicare, they're going to be increasing costs on the commercial side. And the commercial side is basically your private insurance that you get through your employer or you get through the marketplace, which we discussed earlier today. So I think those are going to be a couple of ways that pharma is going to say, hey, if I'm going to pay, huge rebates and negotiated prices on Medicare, I need to make up for that cost. So for plans, plan sponsors, employers, I have to decrease the rebates that I'm giving you. I have to decrease my discounts. So that means your employer might feel that squeeze, and you might be going from having a better covered prescription drug plan through your employer to maybe less covered, or your cost share might increase, your responsibility might increase. We don't know yet. That's kind of one of the potential consequences that may occur in a couple of years once we really see the outcome of the negotiations. Another thing that keeping into consideration, even for those enrolled in Medicare, I kind of mentioned that these individual companies, known as plan sponsors, but you can call them insurance companies that are running these Medicare Part D plans, well, they can increase premium payments and the member out-of-pocket cost is capped and the government subsidies are going down. They have to account for how much money's coming in, right? And a couple of the consequences that even Medicare beneficiaries might start to see is they might start to see narrower formularies. A formulary is basically a list of covered drugs. So they may go from covering 3 or 4 different medications in a specific drug class to maybe 1 or 2. So you're going to have less choices and less options. They may going from not requiring prior authorizations, which are basically reviews for medical necessity on a medication. Prior to you getting the drug, your doctor has to justify why you need to take this to the insurance company. And we might see an increase in the amount of prior authorizations and other similar types of management techniques to basically drive people away from expensive medications and have them take cheaper drugs or generic medications where there's nothing wrong with it, but it's going to be perhaps for those who truly do need the medication, an extra barrier or an extra step they would have to go through that they otherwise wouldn't have. So those are some of the things that are really unknown variables at this point. So it's definitely a great question. And to be honest with you, I don't think that we're going to, if Medicare is able to negotiate these drugs down, I don't think you're going to see those prices reflected on the outside of the Medicare market, and it's really unclear what will take place in terms of both Medicare and outside in terms of how they're going to manage their formularies and access to drugs.
I have a question. So, like regarding that with commercial, like let me talk just on a pharmacy level. Like if I'm the pharmacist, so am I gonna be able to purchase an Eliquis for a Medicare patient that'll be at a different cost than the Eliquis for a commercial patient? Is that how? I don't know if you guys remember, but there were like for all diabetic testing supplies, you can purchase a Medicare and Medicaid equivalent, which I think is like $7, or you buy the retail version, which you're supposed to use for commercial plans, and I think that costs like $40 for a certain manufacturer. Same exact product, but the Medicare one says on the top of the box for Medicare and Medicaid patients only. It's the same exact thing, but it's just priced differently. So is that kind of what most pharmacies should see when purchasing medications for Medicare versus commercial patients? Is that kind of where the direction that they're trying to head into?
That's a great question. I don't know. It's possible where they could have 2 different NDCs. Probably have 2 different NDCs, the national drug code, basically.
Right.
How a drug is identified.
That's how it is for the strips right now. It's like that you get a box for the Medicare, it's a certain national drug code NDC, and then the retail one is a different NDC.
Definitely a possibility. It could also all just be on the back end in terms of how you reimbursed. be the same product. It may not have actually, I don't even know the impact on a pharmacy level, but it could just be rebates shifting on the back end for payers.
Okay.
So it's going to be decreasing the rebate amounts. Adjustments in the rebates don't really change at the pharmacy. Because I think having an inventory of these expensive medications and for two different subsets of the population is going to be a headache to manage. I don't
Yeah.
think that would happen.
But
I
that's
would
how it is
hope
for the other stuff. So it's like, because I mean, what's stopping me from, like, if I'm buying a medication and it's the exact same bottle, but if it's going to, a commercial PPO patient versus a Medicare patient, Medicare's paying me $500 and the PPO's paying me $1,500 for the exact same medication, but it cost me $1,400, then I'm losing money on the Medicare end. So there has to be some sort of, I think, system that needs to be formulated.
Yeah,
I think, which I'm hoping eventually happens.
Yeah, I don't know, but yeah. I think either is possible. I think it could just be mostly back end price shifting, or it could be what you mentioned.
Okay. Sorry, I just thought of that right now, so I had to.
And I think shifting is such a great description here. I mean, look, if the federal government says, "Hey, look, we just don't want to pay as much," the game theory for a lot of these businesses, these pharma companies, are like, "Well, look, I have to make up the revenue from somewhere else. Whether this means a new drug's going to come onto the market and I have to adjust the pricing so it's higher, or I have to reduce rebates to, say Medicaid for all these different states, or even these commercial plans. Someone's going to feel the burden here." And I think it's kind of unfortunate, because there is this population outside of Medicare where there's a lot of people who are under the age of 65, and they're working individuals, and it sounds like to me it's possible that the Inflation Reduction Act might actually increase the pricing for those that subset of the population. But again, a lot of stuff is still unclear. We're kind of still, I think, trying to figure out what's going to be the ramifications. Negotiations don't seem like they're done yet and won't be for a while.
Right.
Anything else, guys? It's a big, juicy topic, and I hope I try to do my best job to make sure it's like a level where our audience can understand, not getting too granular. But if there's any questions, just feel free to let us know.
Yeah, I know. That was a really good topic to cover. I mean, it was definitely very educational. A lot of people don't understand how drug pricing works, and it's important that we sort of understand and educate, our audience what are rebates and what goes on with drug pricing.
Yeah.
Let's just because I do want to kind of flip to the other side of how a lot of these drug manufacturers are responding to this initially. So like you said, like I mentioned, 8 of them have filed lawsuits. I put up a link, like who's challenging the Medicare drug pricing negotiation rule, if you guys want to open that up. But essentially they're arguing that it's a violation of the First, the Fifth, and the Eighth Amendment. I don't know if you guys have any insight as to whether that has any value or any substance, or if it's just they're just grasping at straws. The Fifth Amendment with the taking clause, I kind of get, where it's like taking property without certain. Let me read the exact thing that way we. So it's taking property without due process, or nor shall private property be taken for public use without just compensation. So a lot of these companies have the same few amendments, the Fifth Amendment, as mentioned, I think, in every single one of them, that property is being taken without any just compensation. Do you guys think that's a valid kind of argument for a lot of these companies, or are they just kind of bandwagoning on from one to another? What are you guys' interpretations and thoughts?
I'm not a
Still
lawyer,
too early?
but I think, you define just compensation, right?
Right.
I don't know. Yeah, I think
what's just?
Yeah, it's going to differ, right, from what they think is just, because they're
Right.
pretty happy right now. But we'll see. I think we'll probably know a lot more in 6 to 12 months and see what the outcome is.
Yeah, property rights seems kind of like a stretch here, but again, I'm not a lawyer, I'm not an attorney. Yeah. I don't understand how that works. It's not like the government's like taking it off the manufacturer's shelf and saying, "Hey, look, we're taking it."
Yeah, this is ours.
I would think of like eminent domain here in that sort of situation with like real estate, but obviously this is slightly different. The government just doesn't want to pay as much, so they're reducing the amount. You see it all the time. But yeah, I mean, there's definitely billions of dollars here that are at play, and I don't think these pharmaceutical companies are going to give it up easily. Of course, they're going to file as many lawsuits as possible to delay this. It's tactics we always see in the pharmaceutical industry.
It's just, we always hear about David and Goliath. This just seems like Goliath with a bigger Goliath trying to fight off one another. Like either it's all going to blow up or, something's got to change.
Yeah. I honestly don't know. I really can't tell you. I mean, I guess time will tell.
Yeah.
They're the
It's a lot
strongest.
of time though. It's a lot of time. Like we're going to be we might be Medicare patients by the time all this, happens and gets resolved.
We're not going to have Medicare by the time we're 65.
Or that.
You think
That's
Social
what I was
Security is going to be around? We're running a
That's
deficit right now.
that's what I was saying. I mean, like these cuts need to take place, and it's just honestly, this is the part of that like kind of gets to me the most is that collective sacrifice is needed, and not everyone's willing to hop on board. It's short term thinking from long term sacrifice. So yeah, I don't know if Medicare will be around when we're 65 or even the eligibility requirement I think is 67 now for people that are our age. So yeah, it's I think that's Social
Take off
Security.
2 years right there.
One of the two. It's like either Social Security moved up or Medicare moved up a couple of years. But yeah, I think there's just definitely people need to get on the same page and realize that like, hey, you just can't keep going down this way. I think we've all kind of agreed that we're in a kind of a situation financially that comes to and huge deficits, a lot of debt, and how sustainable is it? I'm not smart enough to know. But just if you're $32 trillion in debt and you have a 6% interest rate, sounds pretty bad. And we got to start making some changes to think long term.
This whole situation just kind of reminds me of that Martin Shkreli, where he just bought up that one truck and just inflated the hell out of the price.
So we can go on a conversation about drug prices like this, like just wonky drugs like HP. Was it HP Acthar? I don't want to badmouth them, but
HP Acthar.
Yeah. So this drug has been around since like the 60s, and it treats various different conditions, but not really an effective medication. And God, I can't remember the pharma company name, but they bought this thing up, and it went from like a couple $100 to like $32,000 a month. It was just wild. This is what they do. They these cheap drugs, kind of reformulate, rebrand, and put them on the market for thousands of dollars.
That's what the standard of practice is right now in pharma. It's like, all right, this one medication is going to go generic, so let's change one molecule on it, rename it as a new brand name, and then we got another 10 or 15 years. Like I've seen that with specialty medications left and right. Abilify, if you guys remember when Abilify went generic, a couple years later, Rexulti came out, which is not aripiprazole, it's brexpiprazole. It does the exact same thing. It works the exact same way, but it's a new med, and it's better. So it's
that was Otsuka who puts it out.
Otsuka. Yeah. I just remember I was like, I looked at it and I'm like, this feels like the exact same thing, but it's not. But it is, and I'm like, I can't tell the difference. And I ask patients, they're like, yeah, it's about the same. I feel the same. I'm like, okay. So
you might want to like tell the audience about the over the counter combinations that we love the most, the ibuprofen and omeprazole combination. Was it like naproxen?
I think it's called
naproxen and esomeprazole.
Yes.
Yeah.
It's basically two over the counter medications like naproxen and Nexium. One's a medication that helps with pain. The other one helps with stomach acid reflux. They took the two things that maybe over the counter would cost you $20, stuck them together, and it's like a $2,000 to $3,000 a month medication.
Yep.
Insane.
So that was when it went generic. I think it's still like $700 or $600.
Still pretty expensive.
Yeah.
Anyways, I'm going to put a pin in this topic for now and move on to another one.
Yeah.
It's a good conversation.
Well, we'll have more updates for our audience on this as the negotiations progress. Obviously, it's from now till 2026, so our updates will be just on that same timeline.
Yeah, 2029, Amber, don't you forget.
Oh, yeah. Gotta
Yeah, we
plan
got
6 years ahead, you know?
a lot of juicy stuff coming out.
I think that's about all the time we have for today. Don't know.
Yeah, we're
Did you,
exactly
James, you want to give
on the
a
hour mark.
quick overview on that SBF thing?
Yeah, no, I mean, if you guys have time, I'd love to talk about the FTX
Yeah,
trial.
Yeah, let's do it.
Yeah, it's just been wild. I mean, we've had, I think, 3 or 4 witnesses testify. So Sam Bankman-Fried, he was the sort of the owner of Alameda Research as well as FTX. FTX was a huge crypto exchange and sort of went under. What they allegedly did was give customer deposits to themselves and other lenders, and it was just a complete mess. So it was just a huge Ponzi at the end of the day. So Sam Bankman-Fried's on trial. There's been criminal charges that have been filed by the Department of Justice, and a lot of it just has to do with securities fraud. And we've had a lot of different people who have testified. One of them was a partner with Sam Bankman-Fried. He was actually like childhood friends with him. But most recently, Caroline Ellison, who was allegedly Sam Bankman-Fried's lover at one point in time. She had a lot of colorful testimony, and one or two things that sort of stuck out to me is they had a lot of funds in China. I think roughly about $1 billion worth of funds that was frozen. And what they would do is they would try to bribe the Chinese officials. I think they spent roughly $150 million bribing Chinese officials to get this $1 billion unfrozen so they can, access it and use it. So that was like, pretty crazy testimony, in my opinion.
15% fee? Not bad.
Yeah, I don't know. I mean, she did admit on the stand that she had to doctor and create balance sheets. She did have to lend or take money out from customer deposits and give it to lenders who were calling back their loans due. A lot of their loans were open, meaning that they could be called back by any time by the lender. So they use customer deposits to sort of fulfill that. One other thing that I thought was pretty interesting, Sam Bankman-Fried tried to suppress the price of Bitcoin by selling it so it would remain below $20,000. I don't think it really had the effect that he wanted to have, but it was kind of interesting that was sort of mentioned. One thing I thought was pretty interesting as well, but I believe this was probably struck from the record. They did mention that, both Caroline and Sam tried to hire Thai escorts or prostitutes to create OK Exchange accounts. OK Exchange was like basically another crypto exchange, and they would use that to trade cryptos, or they would use it to hedge bets. So when they were shorting Bitcoin or dumping it, they would be able to make money by betting against it. So I thought that was kind of interesting, but there was, this was probably really colorful testimony, considering that Caroline was once lovers with Sam, but I think we're going to be in the second week of trial coming up, and the wild card really here is Sam Bankman-Fried is going to be testifying possibly, so we don't really know what he's going to say. There's nothing wrong with a witness who wants to go and testify, but most, I think, defense counsels would probably say, look, like I don't think it's a great thing for you to sort of go out there and say things. You're better off just pleading the fifth in this sort of situation. He's sort of the wild card, and I find that to be the most fascinating part. You've seen him after the collapse of FTX, he was tweeting a lot of different things, and he's sort of saying I'm sorry, but it's just kind of a weird position he's been putting himself in. So it'll be interesting to see, what sort of shakes out. But I think the defense has a huge Hail Mary here to sort of overcome. If I'm the jury and I'm hearing a lot of these sort of things, I mean, it sounds pretty colorful, especially if you're trying to bribe Chinese officials. I think $150 million, that's pretty crazy. So, but yeah, this is, I've been following the trial pretty closely, and, something I do want to share since, we work on a lot of different interesting things, and crypto is one of the things we find interesting, I guess, when we talk.
No, definitely.
Isn't
James, sorry, I still have a quick question. Any idea if this is the federal trial against him? There's multiple trials, or this is the only
I think this is the only one that's ongoing. as I know right now, but there might be more. I don't know is the best answer. There was a campaign financing charge that was brought, but I believe that one had to be dropped. I know the optics from that sound kind of weird, but FTX or Alameda Research did make huge donations to the GOP, as well as
It was a DNC.
DNC as well. He made donations to both. That were pretty big, but I think part of it was that these campaign financing charges had to be dropped because they were extraditing Sam from the Bahamas. And I think there's a neutrality agreement that you can't really extradite someone based on a political reason. So they had to end up dropping the campaign financing charge. And right now, I think they're just sticking with, securities fraud at this current moment.
Ton of fraud.
Yeah, I mean, it's, if it is what it is, then this is probably larger than Bernie Madoff. This might be the largest fraud in the history of mankind.
Did
How much was the
Bernie
total?
Madoff? Sorry, go ahead.
How much was the total?
Billions. Yeah.
Let's see. FTX total. Did
And
Bernie
do you have
Madoff defend himself?
I don't know if Bernie
At the
Madoff
end?
ever.
To me, it just seems, I'm not a lawyer, but if your defendant is taking the stand to defend himself, that seems like the last Hail Mary, right? In every legal proceeding we've witnessed and seen.
I gotta share it with you. So right now there's no live coverage of this, meaning there isn't any video recorder. This isn't that big of a public, or it's pretty public, but I guess cameras weren't allowed. But so there's always court sketchers. They go in and they try to paint things, and some of the drawings have just been so interesting. The way they draw Sam and the way they draw Caroline, and what the judge's sort of reaction is to a lot of different things. Some of them are pretty good. I gotta show you guys.
Make an NFT out of these things.
Oh, I'm sure. I mean, these will probably sell for a lot.
The number is 8.9.
8.9 for Bernie Madoff or FTX?
No, FTX.
Yeah, that's a lot of money. That's a lot of money. I mean, there's not just FTX. I think Celsius was another one that kind of just flew under the radar. A ton of people got pretty bad as well. And that's, until this wild west phase of crypto is resolved with the exchanges and everything like that, I think it's going to be like a rough ride. But I'm glad that he actually got brought to justice. I don't think the founder of Celsius got charged, or was recently got charged in New York only. So I think he should get what he deserves on this one. A lot of people lost a lot of money because of him.
Yeah, I think the next executive that will be testifying after Caroline will be Nishad Singh. He was an executive in sort of in Sam's, I guess, cabal. So we'll be seeing his testimony probably next week. But, a lot of these witnesses have sort of come in and said, look, we're going to be doing a plea deal. We will be cooperating with Department of Justice. And in lieu of that, we would like to have some sort of reduced time or sentence. So obviously, Sam has denied all wrongdoing and all allegations. But, again, I think, the testimony next week with Nishad Singh is going to be very interesting to see.
Thanks, James, for the update on this. I know it's I haven't been following it closely, so it was good to kind of hear that this is moving along.
Yeah. Well, I think that's all the time. It's been an hour, so
wrap it up.
Yeah, nice. We'll sit in for next week, I guess. Well, we do this every Friday and we release it at the same time. So,
see all of you next week.
See you next week.
Take care.